Hello and welcome to our today's online webinar with Dr. Alecsandru Ionescu from Bucharest in Romania. My name is Holger Kast. I'm the Global Training Education Manager for TRI Dental Implants, and I will lead you to this webinar today. And I just would like to give you some rules for the webinar. In case you have some questions to Alex, just write them in your toolbar on the right side. You find the question field. Please write all your questions in there. And we have at the end of the session, we have a question and answer session. So we have enough time to answer your questions. Before I give the word to Alex, I would like to introduce you into our tissue level implant, because today's topic is minimal invasive surgical techniques using tissue level implants. And Alex will show us amazing cases, full arch cases, and a lot of interesting cases on tissue level implants. And so I would like to take the chance to introduce you quickly into our TRI implant system. Basically, we have a very lean surgical kit, and this surgical kit is you can use for 3 different implant lines: for a narrow implant, for a bone level implant, and for the tissue level implant, which is the focus today. And so, as you can see already on this picture, the thread design is the same for tissue level and bone level system. That makes the surgical procedure very easy for both types of implants. So here you can see a picture of our unique tissue level implant. You can already see here the pink color of this tissue level implant, and this has a very big aesthetical aspect. And I would like to show you a scientific study we made with the university in Zurich a couple of years ago to show the discoloration of tissue with different colors of material underneath the tissue. Therefore, we used a 1 millimeter thick tissue layer and placed, for example, titanium, just a gray titanium color, a gold anodized color, and our pink anodized color, and also a zirconium white color underneath 1 millimeter underneath tissue, and measured the color and the discoloration of the tissue above it. And so the difference between a gray titanium color and a pink color is very significantly and has a very big advantage in the aesthetic area. And I'm quite sure Alex is going to explain in his cases a little bit more about this. And so then another big advantage here shown by the bone level implant, as I said, the thread design for the tissue level and the bone level is the same. So the threads of the implant itself, of the TRI implant system, has in the apex area a very aggressive area. We have a triple leaded thread, and you are able to use it in immediate placement and also for immediate loading. And also the top area here, it's important, for example, sinus operation, to get a nice primer stability. And the very important part is we have a tapered design of our threads for the tissue level implant as well. And last but not least, a very big advantage of the system is our so-called friction connection between the abutment and the implant itself. You can see it here. So we have a slightly frictional connection between the abutment and the implant. So the internal octagon of the implant is frictional connected with the external octagon of the abutments, and this gives you a lot of security. There's no screw loosening, and there is no micro movement between abutment and implant, and this is quite unique in the dental world. That was it from my side for now. I will give the word and also the presentation to Alex. Please go ahead, Alex, introduce yourself, and I'm really looking forward for a nice 15 minutes presentation about your tissue level cases.
Okay, good afternoon. Thank you very much, Holger. So, thank you for this invitation. What we are going to see today, okay, good. All right then. What we are going to see today, it's let's say an approach in everyday practice using the tissue level implants. Little words about myself. So I am working in my private practice for 18 years. 10 years ago, 11 years ago actually now, my mentor in tissue level implants, Dr. Georg Taffet from Germany, showed me a little bit the ways, like you see here, the ways of the force with my kids, the way of the force of the tissue level implants. And we started changing our concept and everything about implant dentistry at that time. I'm based as a aesthetic dentist specialist, and then I had decided 11 years ago to switch a little bit more into the biological approach of implant dentists. And I am a member of the board of the Romanian Association of Aesthetic Dentistry, and also I'm a co-founder of Quintessence in Romania, and also author of the first compendium of aesthetic dentistry published by Quintessence in Romanian, English, and this year also in Chinese. So this is my team, and without the part of my team, and without the team, basically I wasn't able to do all these, let's say, nice pictures to show for the cases. A little bit about our hometown. So Bucharest is a very nice place to live, to party, and to develop different ideas like research in implant dentistry, for example. Now, going back to our, let's say, love that started pretty much more than 10 years ago with the tissue level, when we switched from bone level to tissue level implants. The topics for today are going to be some words of the internal sinus lifting with a minimally invasive approach with this type of tissue level implants. The bone splitting, we have again minimally invasive approach for the bone splitting with flapless, I mean flapping less the site, a vertical augmentation, and some implants in the aesthetic zone, which are also in our everyday practice very, very often nowadays. Now, some keywords for today. The difference between flapless, everybody knows flapless, and flapless, it's a little word difference. The open healing concept is our concept that we learned from Dr. Taffet and Dennis Tarnow, the open healing concept for socket preservation, and the use of tissue level implants respecting the biological width and generating happy patients. I am going to insist today on everyday practice cases, like people that are coming to our office and they really need teeth and they want to have some decent solution for their oral health. Now we are going to start with a case. I'm going to show a little bit. This is how the open healing looks. So basically for socket preservation, there is no need to close the free gingival margins. And here is our everyday flapless approach in tissue level implant. So a little bit about the sequences, the punch, the implant insertion. This is very friendly for the patient. And the biological drilling, so basically with a low speed, and we can also collect some autogenous bone if we need. This is one of the old cases with 3 octa. Meanwhile, it's a little bit changed in terms of handling. Okay. So this is a case beneath the pictures. There was a root fracture in the initial situation. This is how our concept of open healing generates the outcome after the healing. and the implants in situ and after cementation. So this is just to start with an everyday practice simple case. Of course, this is the final situation after 2 years follow-up. As you see, crowns on the implants and the clinical situation. The good thing about the 3-octa implants compared with other tissue level implants is that what also Holger said a little bit earlier, that there is a very nice outcome due to the titanium anodized pink color that generates, especially for the thin phenotype, generates a very nice outcome for the gingiva. Now, we are going to start with our topics. The internal sinus lifting is something that can make a difference for the patient when compared to the external sinus lifting. We, let's say, changed our limits from, we started like doing sinus lifting when we had like 5-6 millimeters of residual bone. Now we are also doing this up to, let's say, 4 millimeters and placing 8 millimeters implants. So this is one of the very old cases with 3-octa, I think, with the internal sinus lift and the immediate placement of the tissue level implant. The benefit is that tulip-shaped neck of the implant is also generating, let's say, for the gingiva, it's generating a nice shape of the future papillas. So this is an X-ray with the internal sinus lift. We can see here how the bone went a little bit apical and the exact limit of the threads at the bone level. And also, this is the X-ray and clinical outcome. You will see here that some scars, and after 2 years, biology worked great. Look, after 2 years, we have very nice papilla outcome. Of course, with respect of the Dennis-Turner rule of 5 millimeters from the contact point to the bone. And comparison. Now, decision making nowadays, how can we be minimally invasive when it comes to raising the sinus membrane? So this is a case that we had with tooth 26 and 27. We had problems with 26 at the beginning, so it needed to be extracted. As you see, about 15 years old root treatment. Again, a minimally invasive approach, so a traumatic extraction. We are using as a golden standard for our open healing, we are using BIOS and BioGuide. And as an alternative, when we have the intact walls, we are using PRGF with a quick outcome. This is a CBCT. The problem was that we also had a problem with the 27 tooth, but we did not want to take it out at the beginning. As we used PRGF, we maintained the bone level, and this helped a little bit. Then it was a staged approach. After 8 weeks, we extracted the other tooth as well. Now, for that, as we had no buccal bone, we needed the BIOS and BioGuide and the open healing. You see, basically, there is no tension, there is no flap, and here is the membrane suture with a continuous PTFE suture. And the healing period, after 3 weeks, we take out the suture. And this is the outcome after the healing. Now, at this stage, we needed to decide whether to do an external sinus lift or internal sinus lifting. And having the patient as a friend, then we decided to go with a minimally invasive way and raise in an internal sinus lifting way. Of course, an alternative would also have been a vertical ridge augmentation for that patient, but of course, we would generate a very nice outcome. You can see here the level of the gingiva, and our proposed levels of the future implants and how much we want to elevate. So this is the clinical aspect before the internal sinus lifting. That was our final decision. And the clinical aspect and the X-ray after. You can see the level of the bone that we elevated a little bit together with the sinus membrane. Now, in terms of decision making, of course, we can always have the second alternative with external sinus lifting, that we can do it either with concomitant implant placement or not. But for this type of patients where we have at least 4 millimeters of residual bone, we prefer to do the minimal invasive way, like raising in internal way the sinus. Again, a similar case with internal sinus lift. Both, it was bilateral. Here, it's a mucosal. We leave it as it is. We are not interfered with this. And the X-ray after the internal sinus lifting, we can see how the membrane and bone were raised. Here, due to the thick gingiva, we decided, this is something that we usually don't do. We decided to put the punch back, and then we will reorganize the gingiva when we do the final restorations, such as we have respect to the biological width. And this was the initial situation of this patient. And this is how she looked like. And this is how she's looking now after our rehabilitation. One of the most interesting things about the minimally invasive ways is this type of bone splitting. For that, we have a limit, and as well with internal sinus lift, we had a limit of like 3.5 millimeters, and now we are even going lower than 3 millimeters to enlarge the ridge in order to place an implant of 4 millimeter diameter. So what we do is only a crestal incision that you see, just a crestal incision. And basically, we don't raise any flap at all. So just a crestal incision and only like 1.5 millimeter deperoration here, just to see the edge of the ridge, and such as we are able to cut it. We can cut it with a disc, and we can also cut it or continue the cut with a piezo surgery, of course. Then we enlarge everything from the interior without touching at all the periosteum, and we can also use the Meisinger crest control or similar systems to enlarge from the interior the, let's say, minimal invasive fractured crest. The benefit for that is, even if there is a huge fracture here, everything will remain close to the periosteum, and basically there is no chance for losing these thin plates of the bone. The only problem is that when we have cortical directly to cortical, then it's a problem because we don't have enough blood supply, and we need to be very careful. Now, after we enlarge this and we place the implants, between the two implants, we go back to our concept of open healing. So basically, we don't want to close these gaps. We are going to cover it with a membrane and leave it opened. You can see here how large the ridge is now with a 4 millimeter implant diameter. So we customize the shape of the membrane. We need to take care. There are only two membranes that are able to resist in the mouth opened. It's a BioGuide and a socket repair from the other company. And here is the outcome. I mean, don't try with other pericardium or whatever membranes, because they're just going to dissolve in 24 hours. So this is a clinical aspect after 4 weeks, after 48 hours, sorry, 1 week and 6 weeks. You see, very nice outcome, and the great benefit is that we don't lose the this vestibular space. This is how it looked like, 3 millimeters before, here 3.55, and the X-ray with the 4 millimeters implant and the arch rehabilitation again. And after 2 years' time, everything is very stable, especially the papillae mesial to the mesial implant of our case. Of course, the patient was rehabilitated, and we also fixed the function with veneers, and it has anterior guidance and cannon guidance. I think it's okay from a functional point of view. Again, a similar case, just to go again through the tape. Just an incision on the ridge, then the enlargement from the interior, as you saw, and here is the final outcome. For this case, we were referred to the case by another doctor who wanted to have a very nice outcome of the volume of the ridge, and for that we enlarged and made this bone splitting. Of course, for this particular case, it was possible to insert narrower implants, but this is not the case for the lateral ridges, and especially when we need to have a very balanced function of the future crowns or ridges. So this is again the healing. You see how nice the outcome is. And here is after we take out the sutures, and then 3 months after the healing. Here is a CBCT, so it's like a wider ridge, 4.5. And this is the CBCT after placement of the implant with the ridge expanded, as you saw. And the control, this is going to be taken out. These were just the wisdom teeth were kept there for functional reason, not to have any problems in terms of losing the video. Now, we need to open our minds in order to become minimally invasive. It's very difficult when you are very used to raise big flaps and make the big augmentations, but we need to have this option all the time, that we can also respect a little bit more the biology. Now, we have this case scenario. It's an old patient with old bridge that had problems and pain in the upper jaw. So he was 73 years old when he came to our office with this situation. Of course, in these type of situations, you need to think carefully. We cannot do on these type of patients, we cannot think of all these full arch rehabilitations, veneers, whatever, to resolve all the problems. We just need to take out the problem that bothers him with the pain around here, and to stabilize periodontally speaking the rest of the teeth. And for that, of course, we had different choices. We can take out the teeth. We can think of external sinus lift afterwards. Also, we can think of maybe a socket preservation and then some internal sinus lifting. But for this particular case, we had a different approach. So again, this is an older case. It's one of a series of implants with 3 from 2014. I think it's the first year when the 3 implants were available on the market. So this is the CBCT scan. So you can see that we had this tooth number 24 that is going to be hole on the arch. And we wanted to have the bone level from here generating the bone level and dictating the bone level of the rest of the case. And for that, So we kept this. We took out the other teeth, especially this here, and also the wisdom tooth with the traumatic extractions. And we decided to augment the ridge vertically. So again, we did not raise the flap. The only 2 millimeter that we needed to make a deperoration at the edge of the free gingival margins, just to fix with pins this titanium membrane. Everything else is kept on the spot, no deperoration at all. And this is how an open heal, a larger open healing with titanium mesh beneath is looked like. And here is the healing aspect after 24 hours. And then, of course, we had a follow-up for this patient because it's not the type of case that we do every day. So we need to make sure, especially for a 73 years old patient, that he is able to clean, and we need to make a very good bacterial control over that. So here, after 3 weeks, we can see that already we have gingiva starting beneath the titanium mesh. And after 1 month, 6 months. Of course, we had this small problem here, but we just rounded the edges with a burr, so everything was stable. If in such a case, if the membrane is becoming unstable, then it needs to be taken out, even if it's before 6 months, because it can compromise the entire surgery. So this is the X-ray before and after the surgery. And a minimally invasive removal of the titanium mesh and a few more days to heal the soft tissue. And then flapless implant placement, and again mounting the abutments, and after 4 months, and we were able to take the impressions. And this is in 2014, the clinical situation after the cementation. And you can see how nice the outcome of the bone here. We can see the bios, how it left there, and the level of the bone that we had on the 2-4 remained for the entire arch distally to that. Now we started calling this patient for follow-ups, and now we have 2 years follow-up in 2016. This is the CBCT scan. You will see that, I mean, you see different because it's just a picture from the CBCT scan. You see the papilla, how nice, and the gingiva and the free. Imagine with a big flap here, how was the vestibular space left with a big flap? Of course, we could have done vestibuloplasty, but for that, without any deperoration, this fixed gingiva remained as it was before. Now again, in 2007, we have these control pictures. We use some bouncers for to see the nice outcome after 3 years of the fixed gingiva here. And of course, the X-ray, and we can see again that the level of the bone is maintained. And we also asked the patient to come last week to have this 2018 follow-up and a new X-ray, such as we can show you at this webinar the outcome. Of course, we have a very small chipping here of the ceramic after 4 years. We will think of repairing it, but as I told you now, the patient is like 77, and he's feeling very well, and everything is very good for him, especially that all the maneuvers were minimally invasive. And as you see, it's a perfect stability of the bone and the soft tissue. And now the comparison and how it looked like, the bone level before the treatment and the bone level that we got after the treatment, and that the same level of the bone that remained after 4 years with this biological concept. And the CBCT scan, such as you can see how we did the internal sinus lifting here. So basically we had in the same case two minimally invasive approaches. One was that, let's say, vertical augmentation without raising flaps, and then we raised a little bit internally the sinus membrane, such as we can place longer implant here, just to have a comparison. So this is the X-ray of 3 oct after 3 years and 3 oct after 4 years. It looks very nice and stable. But we need to enjoy this type of surgeries and regenerations, but all the time we need to think about the patients. Of course, there are maybe 90% of the cases that can be done minimally invasive, and for the rest of the cases we can do a normal approach, but minimally invasive need to be, let's say, somehow placed in our minds as an alternative for the treatments, with respect of the biology and of course with the respect to the patients. Now I'm going to go back to an everyday practice case, because this is how we meet our cases in our everyday life, and the patients who usually have older treatment, and most of them are coming, maybe they think they need some aesthetic changes, maybe they need some bite changes, but to get the general idea, we need to have a very good explanation of the future result. And for that, we always do the backward planning concept. So the patient is coming, we try to foresee how he's going to look like in the end, and then we are trying to respect that project, both for implant placement and for prosthetics. So this is the initial situation in 2014. And some details: there was a big lack of function and spaces between teeth. Again, what we know best, we did some extractions with open healing concept for socket preservation. Every time we don't have at all the buccal bone, we use a membrane with the ice cone technique, originally imagined by Dennis Tarnot and modified by Dr. Taffet, and then taken out by my team as well in our concept 10 years ago. So this is how it looks like. We insert membrane up to the apical bone where the entire buccal bone is missing. Then we augment, and everything is remained opened. There is no touch of the papilla, no touch of the periosteum, nothing at all. Just put a PTFE. It's very important to have a PTFE suture because of its properties. And this is how it looked like after the healing, and then punch tissue level implant placement. We had also a problem during the treatment because of the, let's say, extended provisionalization. We lost another premolar, and here we had to take out also traumatically. You can cut the roots like this, from vestibular, from buccal to the palatal, such as when you have a monoradicular, not to put pressure on the buccal bone, especially when we have the buccal bone and it's very thin, and we want to immediately insert the implant, like it was for that case. So it was a combination between open healing and immediately implant placed here. And you see, this is a case where we did not, let's say, over-treat. Quadrant 1, we had 1 implant and 2 retreatments of the existing roots by our endodontist on microscope. Then we had an external sinus lift here, and for that implant, and for this one and this one, it was the one that fractured afterwards. We remain with the same situation, and teeth retreated in this quadrant, and here we postponed a little bit the treatment, but due to the change of VDO and the entire design of the teeth, we decided to take out the old bridge and put a provisional one with a correct design. So it was like a, let's say, a small compromise for postponing this part of the treatment. So we did, in this case, everything that you see here, like we started with open healing, we used tissue level implants, internal sinus lift, and external sinus lift. We respected the biological width and then external rule for generating and regenerating the papillas, with both with provisional and final prosthetics that respected the exact function. So everything, all these are connected to biological thinking, and all the time that we can do and respect biologically, and we do a teamwork and a backward planning. This is our everyday practice strategy. So it's again the beginning of the case, and here is how the case looked like last year. And now clinical situation. Of course, also from aesthetic point of view, it's a very nice outcome. We have the function, we have everything. Here are our implants, and we can see it's an emergence that is going straight from the neck of the implant. This is something that is available for the tissue level implant, that the crowns are cemented directly on the neck of the implant. So again, this is the final restoration and the Canon guidance here that is going to protect everything, and this is a 1 year follow-up. Everything is in place. Now, this case, it's a special case for us. Not that it's a special case in terms of the approach, but my colleagues got an award last year at the Aesthetic Dentistry European Congress with this case presentation as an interdisciplinary approach. So I'm going to go through it a little bit. It's again what we see in our everyday practice with problems, old treatments, and this that needs to be extracted, and we are thinking again minimal invasive. And this is our treatment. So here we lost one tooth and the molar, one implant with internal sinus lift here, another implant inserted post-extractional here, the other two teeth retreated on the second quadrant here, just retreatment, and two implants placed on the fourth quadrant. So this is an everyday practice, let's say, final outcome of this type of treatment. And of course, there was a nice outcome in the end with the patient and a good function that respected the guidance and everything. And this is the final outcome. Of course, we do some nice pictures with this type of cases just to have. And now we are going to, this is, I think, the last case before our question session. It's a case in the aesthetic zone. I started with everyday practice cases because our last webinar was dedicated to the difficult cases in the aesthetic zone, but we use tissue level implants in everyday practice as well. So both for lateral zones and also for aesthetic zone. As for 10 years, we are only using tissue level implants in our office. Of course, handling an aesthetic zone case is all the time it's more difficult, but respecting this concept of minimal invasive approach, we can generate a good outcome for the future cases. So we had endo, not necessarily endo, but root failure. This is this patient is fan of football team, and even in his everyday life, it's a very, very serious person. When he's going out to see his favorite team, sometimes he meets with other, let's say, fans of the other team, and they had some not friendly body touch. And one of these body touches generate some destruction of this root. So he had a fight, and he had a fracture of tooth 1-1 about 3.5 years ago. So because he did not come immediately to our office, it was micro movement and the bacteria who allowed the bacteria to destroy a little bit more the buccal bone. So he had no buccal bone. We were not able to insert the implant immediately. So we had to extract the tooth, and then used our open healing concept and augment the ridge as described before. So we insert the membrane, and we place the bone granules, and the bone granules are going to fix the membrane with the pressure that is occurring here on the buccal bone, on the buccal gingiva, sorry. Buccal bone is not there. So this is a close-up, and you can see that we did not touch at all the here at all the papillae, and we did not touch the periosteum. So a continuous suture with PTFE, it's the most important thing, because the PTFE can a little bit, it's not generating tension on the free gingival margins. So this is immediately after the surgery, and from is usually from neighbor teeth, and we use rubber dam when we attach it, not to have any composite going to the surgery situ. So this is how it looks like, and this is a good outcome. The situation is stable. After 6 months, we measure, and this is the healing. Of course, we lost a little bit because of the bone of the adjacent tooth, and we have decided to change both the crowns in the future. So we inserted the triopta Flapless with respecting, of course, rules that we know from for 3D placement. After 6 more months, this is the situation and the comparison between the fixed abutment on the tissue level implant and natural tooth, and the two crowns, metal free, that were fixed and cemented juxtagingivally, exactly like comparison with the natural tooth and the implant, and with a respect of 5 millimeters Dennis-Turner rule from the contact point to the bone, such as we can have the faith that the papilla will be here and remain here. The outcome, the benefit with the tissue level implants is that the outcome of the gingiva remain the same, because the shape of the implant is the one that generates the final outcome. So there is no need on any abutment changes or soft tissue management at all. And this is the situation in 2016 and in 2017, and you see that papilla came down all the way. And we wanted to have this patient also with a follow-up in 2018. Now, before that, I'm going to show you the initial situation. So the fracture was here. We had the bone up to here, and we needed the bone up to the yellow arrow. After the open healing concept, you see the native bone is there, and this is the outcome of our ridge preservation. Now, As we did not raise any flap for implant placement, here it was and it still remained a very stable situation. Now this is again after 6 months after the implant placement, and the implant is already also integrated. You can see the provisional crown, not that it's a space between the provisional crown and the implant, so it was not connected to the implant. And again, after 1 year of crown in service. So we can see that we have the bone remain there up to the last thread. So here is a biological width distance that is usually generated by the tissue level implants. And here is a close-up after 2 years in service for that crown of the implant. You can see a very nice outcome of the fixed buccal gingiva, and the comparison between the tooth and the natural tooth to one, and the crown on the implant, both cemented juxtagingivally on their preparations. And this is part of the biological thinking and its beauty. And the implant versus the natural tooth. Now, this patient was asked to come for a follow-up in 2018, and he came. But before that, he attended again a soccer match. So when he came, he had 2-1 fractured, and we had to take it out. And this is just a teaser because the case is still undergoing. It's a teaser for the same case that we were thinking to present as a nice case with an implant in the anterior zone. Now we are going to present a nice case with 2 implants in the anterior zone. We are going to respect everything we know about biology, and we are going to show the final outcome as soon as it will be possible. The difference is that for that implant, it was delayed placement, and this is the outcome. And for neophyte, we were able to extract and place the implant immediately. Again, it's flapless, but the bone was preserved. So he fought, and then he immediately came to our office, so he did not lose the buccal bone. This was the difference. So it will be very interesting to see in a few months the final outcome for that. And now, after 10 years, I go again through our, let's say, keywords: minimal invasive, open healing, flapless, the tissue level implants, and of course, the patient comfort. When the patient has comfort, the team also has comfort. We don't need to answer our mobile phone during night, because nobody is going to swallow or have big problems with this type of surgeries. So be minimal invasive and think biologically. Open your mind to the open healing concept. It's a very good concept. And let's go back to what we learned more than 20 years ago using the tissue level implants and the biological width. And we need to respect ourselves and go only on evidence-based dentistry. And remember that the patients don't want multiple surgeries. They just want to have beautiful teeth. This is again one of our patients with upper veneers 10 years old in function and lower veneers new. And we like to have fun with some patients and make some nice pictures like this here. And thank you very much for attending. And here is my email address and our minimal invasive age tags. Thank you.
Thank you very much, Alex. It was a very impressive presentation with amazing cases. For me, it was really nice to see the explanation of the last case, which we have quite a long way to do, because we just did a case of the month with this case, and there's a follow-up, so it keeps staying interesting for the future. And it's very great to see how your minimal invasive way works with patients. And because I just talked about the last, let me first of all share my screen. The last case, Ich kann nicht mehr share. Hallo. Ich bin nicht mehr da.
Ja.
Okay. The last case, there was a question actually from Kaudar in Tunisia, and she asked, why did you choose a size of implant, I think it was a 4.1 or 4.7, and not a 3.7 diameter for this last case, because you first grafted and let it heal for half a year, get some bone, and then you place an implant with a wide size. And so the question is, why not placing a 3.7 instead of a 4.1 or 4.7 implant? I don't know what it was. I think a 4.1.
Yes. First of all, there are two answers for that question. We usually, to get this type of outcome, usually when we place the implant, we can also enlarge a little bit, like a bone spreading from the interior. So we go only with the first two burrs, and then we go to with an osteotome and enlarge the bone plate, such as we get this emergence of the tissue. Because if you go with usually we don't do any augmentation on a second approach. So when we insert the implant and enlarge a little bit from the interior, like in bone splitting and expanding the ridge, then it will generate a very nice outcome similar to the one that you have with a natural root. If you go with a narrower implant, then this is not going to remain stable, because if you want to enlarge, then you need a wider implant. We also have cases even with wide neck implants in the anterior zone, because there is also need to compare the width, because for tissue level implants, the width is generated by the platform. The implant itself, it's a platform, so you cannot enlarge the platform or do anything else. So even if it has 3.7 or 4.1, this is 4.8. If we wanted a larger platform, then we needed a wide neck implant, for example, for tissue level. So there is no need for us to do this, because it's generated by the let's say the diameter of the neck of the implant. And to answer exactly why we did that, because it's not shown in the pictures, we enlarged a little bit from the interior during the surgery. We enlarged a little bit the bone from the interior, flapless.
Okay.
Speaking.
So
and then we had this outcome. Otherwise, with a narrower implant, here it was a little bit shallow.
Okay. So we go on with questions. They're coming in more questions. Just for your information to all participants, if we can't answer all questions right now, we're going to pass them later on to Dr. Ionescu, and we try to answer them later on. But there was a question, what tools did you use for the internal sinus case? Which tools did you use?
Yes, there are different tools that can be used. We use some osteotomes from Helmut Zeff. It's a little convex shape at the apex of the instrument.
Okay.
And we use a hammer to do it.
Then the drilling protocol, is it the slow drilling protocol, is asked by Julie Gatzberg.
Yes, we learned that from actually from Professor Anitua in Spain. We've been there in his clinic, and he had a very nice study with biological drilling. So it's 150 rotations per minute without liquid. So
That's
this
one.
is the
Okay. There's one question from Dr. Safet from Macedonia. I think this question is already answered. Do you use 3 tissue level implants in the front region or bone level in the front region? And I think the last case showed that you place actually in the aesthetic zone, which is the topic today.
In the last 10 years, I did not use any bone level implant at all. I only used one time 3 bone level implant because you asked me.
Okay. So that's nice. There's one I say like last question from Mario Stinu. He asked if you do immediate loading. I think first he asked on the healing color, but then it's on temporary. Do you do immediate loading with the TRI implant or do you mostly let it heal and then go with the final restoration?
I have a very, very, very good friend named Marius Dinu. Maybe it's him, and if it's him, I'm very glad to answer the question this way. Of course, he can also call me and answer the question. But what we do when we can avoid loading, we avoid loading. When we cannot avoid loading, we do the loading, and we are a little bit. Let's say a little bit more stress with loading, and usually we do this loading when the patients are leaving and coming back after 6 months because they are not living in Bucharest or in Romania. But we also do immediate loading, but as I said, when I can avoid, I avoid. But we did not have any problem until now with immediate loading, but in terms of percentage, I think we do like 85% we avoid, 15% we do it because we don't have any other choice. But this is the answer.
Okay, thank you. So I would like to stop here the questions, and we anyways will pass these questions to Alex, and we can send you an answer later on for all your questions. And I would like to take the chance to announce our real course in Zurich on the 13th and 14th September this year. So everybody who is interested to get more detailed information about tissue level implants in aesthetic zone and the minimal invasive technique of Alecsandru Ionescu, we have a course program, and the next possibility to join this course with Alex and me is going to take place in September the 13th and 14th in beautiful Zurich. It includes a production visit of our Swiss production site here in Zurich, and so I'm really looking forward for this one, Alex, with you. And so the next webinar is also important to keep and save the date. It's going to take place on the 6th of June. The topic is going to be all about a digital workflow from planning to the final crown, also in high aesthetic regions, with Dr. Thorsten Kamm from Germany. He is more using bone level systems, but it's interesting for the digital workflow, where we developed last year a lot of new great products at TRI. And a very interesting thing for the participants from down under, there is still a few places available. So I'm going to be in 2 weeks time, I'm going to be in Australia, and we have the advanced all on TRI technique course with Dr. Luis Bessa from Porto. And so if you are close to Australia or would like to participate, please contact us on our homepage or through our email addresses. And then there's another very interesting course with Marius Steigmann, Dr. Marius Steigmann, also from Germany, in Ibiza, which is a beautiful place for sure, and also a great 2 days course and opportunity to learn a lot about soft tissue management in Ibiza, including some nice evening events. And And last but not least, we have a big more course program for 2018. And so go, if you like, to our homepage and see the whole global education program, where there's really attractive courses, webinars, and so on for the 2018. And also there's some announcements for 2019 already online. Okay, and last but not least, if you are not a member, a follower of our Facebook site, please get a member of our Facebook site and stay tuned for the next webinars, for our case of the month, and so on. And so that's it from my side. Alex, again, a big thank you for this great presentation. I'm always amazed about your way of taking pictures. It looks like you I don't know, who take the mouth out of the patient and clean everything, and it's really amazing to see the high quality of your way of taking pictures and also presentation.
So they are just inserted in the presentation with no modification of at all. You can see it here.
No, it's my slide now. You can't see your slide anymore.
All right.
Okay.
Good. Thank you for
very much.
Have a nice day, everybody.
Go ahead.
Thank you for watching that, and we'll keep in touch. And you can always contact me if you have any questions on these concepts, minimally invasive. I'm more than happy to have some more people in this boat of minimally invasive approaches.
Okay, thank you, and have a good day, everybody. Bye.